Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. Participation in this presentation is by express written invitation of the AHA only. Unauthorized participants and or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the phone and log off the webinar if the AHA did not expressly invite your participation. You may submit your questions electronically at any time by using the chat window located to the right of the slideshow presentation. Underneath that, you'll see a window labeled Files where you may download handouts for today's conference. It is now my pleasure to introduce today's first presenter, Mr. Chris Hund.
Thank you so much, David. Hello, everybody. Good morning or good afternoon, or perhaps good evening if you're outside of North America, but welcome to the AHA Team Training's February 2020 webinar on measuring TeamSTEPPS culture using the T-TPQ, or the TeamSTEPPS Teamwork Perceptions Questionnaire. As David said, I am Chris Hund, a Senior Director here at the AHA Center for Health Innovation and Director of AHA's Team Training efforts. Just some rules of engagement today. You can listen to the audio for the webinar in two different ways. You can do so through your phone. If you do that, you're going to want to mute your computer speakers so you don't have any weird radio-style feedback. Or you can listen through your computer. If you have a solid internet connection, sometimes that's a good way to go about it. We'll have a Q&A session held at the end of the presentation. So the way that we like to do this is have you chat in questions as we go through the presentation. If your questions are more of a technical, logistical nature, we'll answer them right away. But if your questions are content-based for the presenter, I'll create a Q&A and ask our presenter at the end all about what you wanted to know. We are in our second month here of offering continuing education credit for the webinars. So to receive 1 credit hour for this webinar, you're going to have to follow these directions. Make sure that you've created a Duke OneLink account. Instructions can be found in the file pod, which is at the bottom of your screen. So it says instructions for CE credit. That's the PDF you want to download. You could also email us with questions. If you've done this last month and you already created a Duke OneLink account, you don't have to do it a second time. Then you're going to text the phone number on the screen with the SMS code that you see there, YASNAM, within 24 hours of this webinar, and you'll receive your credit at that time. So it's very important you do that within the 24-hour period of this webinar because that's the only window this is open if you want to receive that 1 continuing education hour credit. That credit covers CME, nursing, pharma, all different types of things. So if you're interested, go ahead and do it. Okay, some upcoming team training events offered by the AHA. We have a variety of courses. Whether you're brand new to TeamSTEPPS, you're looking for a refresher, or you're interested in what you do next after you've started your implementation, we have a course for you. So you could follow that URL that's highlighted where it says registered now to look at the different courses. We have master training courses, fundamentals courses that really just go through the tools, and then our next steps workshop, which is something that is relatively new and really helps you take your implementation from kind of the baby steps that you take in the implementation period of the master training course all the way through a more advanced and in-depth implementation. So check that out if you're interested. Our conference is in New Orleans this year from June 3rd to 5th. Early bird registration's open right now, so you can get a lower price point. It's a great networking event. That's a big selling point of it. Everybody really gets a lot out of that. and it's a highly interactive event. The sessions are all supposed to have, takeaways, those kind of like aha moments that you really, can connect to your practice. We want you to be able to come to our conference, plan what you do next, and then actually have action items to take home. It covers really any topic involving team-based care. So it's much broader than just TeamSTEPPS. So it's a good event. It's really where the community gets together every year. So if you've not been before, we'd love for you to show up. We're also doing a call for faculty right now. We're looking for strong interprofessional teams that are interested in helping us in our journey to really, truly, fundamentally change the future of healthcare. So we have a great faculty network now. We want it to be larger. There's a lot of need for this. So you can download our call for faculty following this link if you're interested in joining the team. And last but not least, our webinar next month is on March 18th, which is a Wednesday from 2 to 3 Eastern Time, and it's about resilience and TeamSTEPPS and how these things complement each other and really lead to a more engaged team. So love to see you on next webinar too. If you have any questions, here's our website, there's our email, as well as our phone number. So we strive to get back to people within a day. So please contact us if you have questions about any of our offerings or about content. We're here to help. So please give us a ring or shoot us an email. Okay, without further ado, I'm going to introduce today's presenter, Phyllis Tour, who's TeamSTEPPS Program Manager Nurse Consultant with the U.S. Army Medical Command. I've known Phyllis my entire time working on TeamSTEPPS related work. She's there before I was and has done amazing things with the Army and has always done some really interactive and interesting presentations at our national conference every year. So I'm really pleased to have her on today's webinar so that she can share her and her team's expertise on utilizing the Perceptions Questionnaire to enrich your TeamSTEPPS experience. So Phyllis, tossing it over to you.
Hey, Chris, thank you so much. That was very sweet, and it's been a real journey for us, and we're really excited to be here and to be able to share what we're doing in the Army. Just a little bit about me. I have been a nurse for 35 years. I've got ED experience and critical care, and after some time I found my way to the U.S. Army Civilian Corps and Patient Safety Manager. I was the Patient Safety Manager for a small hospital in the Army, U.S. Army Heidelberg Medac, and in about 2007, as a new Patient Safety Manager, I struggled to find evidence-based solutions for our patient safety challenges. Specifically, the number one issue that we identified at the time, which was communication, and that was prior to the T-TPQ, the TeamSTEPPS Teamwork Perceptions Questionnaire. And in my research to try to find these solutions, I found TeamSTEPPS. And even though it was part of AHRQ and DOD, it was something I had to dig to find. And since then, and since implementing TeamSTEPPS in that hospital, clinic by clinic, it was a great game changer. It changed everything for me on the front lines. And I've since moved to the corporate position, as Chris had noted, at Medical Command. And here we encourage every patient safety issue be reviewed from a teamwork, TeamSTEPPS point of view. And we rely on the tools and strategies of high-performing teams, aka TeamSTEPPS, to provide solutions. We also depend on the Perceptions Questionnaire, the T-TPQ, to help guide us in our patient safety and TeamSTEPPS improvement goals annually. So with that being said, next slide. Okay, the next slide has our objective. This is why you're here, talking about how we do this at our large hospital system. But all of this does translate to smaller facilities, even clinics, how to leverage these results to maximize teamwork improvement efforts, and how to understand how the T-TPQ measures TeamSTEPPS, which has been very important to us. So what I'd like to start with, if I can, is a bit of a polling question. It's a great way to get some situational awareness about the team out there. So really, what level of familiarity do you have with the T-TPQ or the Perceptions Questionnaire? So this is great situational awareness for me to be able to see this. So we'll make sure that we help steer this towards the team that we have here. And for those of you who have experience, don't hesitate writing your experiences in the chat box. I may not be able to read them as we go, but the team at AHA will certainly keep me informed. So at least half of us have no experience at all, and hey, that's where we all start, so this is good. I'll move on to the next slide. So a little bit about, I'm jumping too far ahead, I apologize. Thank you, whoever's helping me. So a little bit about the Army TeamSTEPPS implementation history. We started our TeamSTEPPS in 2005 in the military health system. For the military health system, the integration of teamwork training was mandated by Congress, by the National Authorization Act of 2001. And to this goal, in 2003, Agency for Healthcare Research and Quality, AHRQ, and the Department of Defense Health Agency convened a national panel of experts on human factors, on human error, medical team training. They brought together approximately 30 of the nation's leading experts, discussed the needs, requirements, and strategies for effective teamwork in healthcare. And TeamSTEPPS was born out of that. It was rolled out in 2005 for the military health system, so for the Navy, Army, and Air Force, and later in 2006 for the public. And for most of you, I believe you know that TeamSTEPPS is in the public domain, and all of this information online you can use. So in 2005, it was rolled out for the Army. And typically, in the Army at least, it was rolled out by department. There'd be a department either because of a sensible event, an RCA corrective action, just a patient safety concern, that they would ask to have TeamSTEPPS training. So when you have an organization as large as ours, one facility at a time, that could make implementation initially pretty slow. And typically, when the trainers that went out initially went from Department of Defense, eventually MedCom, Army Medical Command had their own team of trainers, and we would go out to one facility, one clinic at a time. In 2001, our CEO, also known as the Army Surgeon General, requested that we change our approach to TeamSTEPPS integration, and he required the development of a full organization implementation plan, so full Army. As part of that plan, we were required to come up with a measure for our teamwork culture and how to measure our implementation plan. So just so that you could have a kind of a visual of who we are, this is a map of our different Army facilities. In 2011, the U.S. Army hospital system consisted of 34 hospitals or healthcare centers, 8 of which were huge, large medical centers. And under these also are the same number of dental facilities. When we talk about our healthcare system, it's medical and dental. And we have freestanding dental facilities that have numerous small facilities within them. So it's a rather large conglomerate. A total staffing of over 7,000 in our organization. At the time, our hospital system was divided into 5 regions. It made it a little easier to manage that way, and enterprise-wide governance emanated from our corporate level, which is where I work now, or the Army Medical Command. And in 2011, I still considered myself a pretty new staff member here. I was told that I would be the TeamSTEPPS program manager, but it was still in its infancy. I had other jobs. But when the governance and the order came down from our CEO, the Surgeon General, my job was about to change. So when we initially developed our full organization plans, our goals were, and reiterating a couple of things on the other slide, number one, we thought to have a TeamSTEPPS advisory board comprised of TeamSTEPPS master trainers for all medical facilities and dental facilities embedded in that facility. We said that individual hospitals needed to take responsibility for their own TeamSTEPPS culture implementation. We would be the guiding force. We would provide support at the corporate level, but facilities needed to be responsible for their own. Each facility was required to develop an initial plan, and they're still required to have an annual plan, but that same year, customized full hospital facility implementation plans, and then also baseline data to better understand the current teamwork culture that we were in and to have data to be able to measure against as we move forward. Of course, of these goals, I'll be focusing on the third, measuring teamwork culture. And as a sidebar here, for those of you who are considering implementation at a small clinic or a single hospital, again, everything that I share here translates. And I know this because of my first-hand experience with implementation at that small hospital. And then for the Army, we took that plan and just expanded on it to develop the fuller Army plan. So just for fun and for the situational awareness of the team, would you mind chatting in the chat box, or would you mind typing in the chat box where you might be considering using the teamwork survey or the Perceptions A teamwork survey for full organization, for hospital, for clinic area, etc.? Lots of hospitals. I see some clinics, some no plans, which is fine. Hopefully you'll get some ideas. Great. So it looks like a fair amount of clinics and hospitals. This is really great essay, situational awareness. I appreciate it. I see someone's using it. It looks like it's going pretty fast, but it looks like there's some research studies going on and thinking of using TeamSTEPPS. We've had quite a few of our clinics use the TeamSTEPPS interventions in their clinical PI and their research. And we've had some stuff that our teams have actually published related to that. So great work. That's great, great situational awareness. Thank you. So, as many of you know, measuring teamwork is extremely difficult, compounded by the difficulties of the live healthcare setting. We needed a valid metric that didn't require the extensive work needed for measuring live teams through observation. Our team went back to AHRQ, to the resources there, and looked at 2 tools that they had validated for survey options for TeamSTEPPS. One was the TeamSTEPPS Perceptions Questionnaire, and the other the Attitudes, TeamSTEPPS Teamwork Attitudes Questionnaire. Both were designed to measure teamwork based on the TeamSTEPPS system. The T-TPQ, the Attitudes Questionnaire, however, measures how an individual approaches team-related issues, but not necessarily how the individual perceived the current state of teamwork within their team. And I'll give you an example. So in the TeamSTEPPS Teamwork Attitudes Questionnaire, in the communication construct, under the communication construct, question 28 asks for their opinion of this statement: I prefer to work with team members who ask questions about information I provide, versus a similar question in the perceptions questionnaire, which asks staff verbally verify information that they receive from one another. As you can see by how these questions are stated, the attitudes questionnaire is measured on how staff feel or what they like about TeamSTEPPS, whereas the perceptions questionnaire gets to the question of how well we are using these tools within my team. So it's the team member or the questionnaire taker's perception of how well they're actually using the tool within the team. It gets closer to the level of assessment that speaks to transfer of team behavior to the job without direct team observations. And as you all know, Army Medical Systems decided to go with the perceptions questionnaire. Now, the perceptions questionnaire is a 35-item self-reported tool. The questions focus on individuals' perceptions of a group-level behavior. Respondents rate their agreement with items on a 5-point Likert scale, so strongly agree, agree, neutral, disagree, strongly disagree. We rate those 5 to 1 in that order. Most questions in this questionnaire relate directly back to a TeamSTEPPS tool or strategy, so the questions themselves are giving you the answers you need to follow. It's a great tool. Measures of staff perceptions are measured by the constructs of TeamSTEPPS, so those 5 constructs you see there. What the T-TPQ has given our organization and each of our hospitals, dental facilities, and right down to the frontline clinics is the capacity to focus our teamwork improvement efforts based on evidence or data. Each of the T-TPQ questions I said before points to a specific tool or strategy to focus on for improvement. So our teams, instead of spreading teamwork improvement energies thin, trying to correct every teamwork issue we believe we have, we can concentrate our efforts on a few evidence-based improvement goals and do these few things well. So that's really what we have been able to get from the perceptions questionnaire. So I thought it might be a good time to stop and take a look at the questions on the T-TPQ, just in case if we had a few people out there who were new to this, which we do. The AHRQ, just to note that the AHRQ T-TPQ manual, the perceptions questionnaire manual, has been sent to you for this webinar, and the questions are also in the back of that manual. The questionnaire can also be found online on the AHA and AHRQ websites for you to use. This is in the public domain, so you can download these and use these. All right, so before we go on to the next part of the perceptions questionnaire, let's have a little bit of fun and play Name That Tool. Okay, so some of you might be new to TeamSTEPPS, and we did put the user guide, the TeamSTEPPS Pocket Guide or sent that to you. But if you were to get this answer as one of your lowest scoring in your leadership construct from your perceptions questionnaire, what tool might you focus on in your improvement efforts? So my supervisor or manager ensures that staff are aware of any situation or changes that may affect patient care. What tool might you focus on? So you might not know the perceptions questionnaire, but you do know your TeamSTEPPS tools. That's very exciting because most of you are saying huddles. Now, there's really always more than one way to approach teamwork, and you can use different tools, but huddles is intended for changes. Now, I will say that we also use the word huddle sometimes in real life, interchangeably with brief. But for TeamSTEPPS, a brief is for planning and huddles are for changing. And again, note the way the statement on this question is worded. They're not asking what the respondent thinks or feels, but rather a statement of how a team member perceives teamwork actually happening within their team. Great, this is great. Fun, thank you. All right, so then the rest of the perceptions questionnaire is the following three constructs: mutual support, situational awareness, and communication. And again, 7 questions in each one of those areas. And you know I'm going to have you play another game. It's going to be, name that tool one more time. This is question 6 off of the Perceptions Questionnaire. How well we feel or perceive staff advocate for patients when their opinion conflicts with that of a senior staff member. So if that was a low-scoring item on your Perceptions Questionnaire, pretend, what tool might you use? And you guys got it on this one. And, you know, when I look at these, I can make an argument for each one of these being right, but the most correct one, or the one I would choose at least, would be TEPPS. And there are other tools that work well for this that were not part of the selection. You could use CUS, you could use challenge, or the action of advocacy and assertion. So this really gives you an opportunity to see, when you're looking at these questions overall, where to focus your teamwork improvement efforts. So going back to the full Army T-TPQ administration, how did we do that? How did we administer this Perceptions Questionnaire to all the facilities we have? Well, first we opened it up. We gave everybody 4 months, and sometimes we would adjust the time depending upon what else was happening. But 4 months was our goal to get this completed. We had a goal of at minimum a 20% completion rate, and we used the Joint Commission recommended sample size for that 20%. At the Army, we built the questionnaire on SharePoint, which is our internal CarePoint, CareLink. Most hospitals have one of these, so this is an internal way for us to communicate. The advantage to this was that it was no added cost. We already had the platform. It had a survey function, and we simply could send the link to that out via email, and it had the ability to export into Excel, so it was pretty easy. To encourage a real strong return rate, we actually provided the compliance rate every 2 weeks to the individual facilities. We would send the survey completion rate to all facilities, and they could compare themselves to everybody else, which set up a little bit of a competition. Some of our facilities wrote us back and said, hey, could you give it to us every week? And by the way, we want to know by unit. So some of them were pretty competitive over getting this done. Some of our hospitals requested weekly updates, again, to get ahead of the pack. And then I told you we started this in 2011, but we have collected data organization-wide almost every 2 years, roughly 2 years since 2011. We have over 100,000 surveys that we collected since that time. So the data that we have for our organization is pretty vast. And we utilize this at the corporate level or the enterprise level or the MedCom level, so at our toppest level. We also provide the individual hospitals and dental facilities their own data so that they can utilize it. And we can get the data down to the unit or department level so that they can do their own assessment, and departments can come up with their own plans, which is really the best practice. Our teams, I had mentioned earlier, are required to have annual patient safety TeamSTEPPS plans that are combined. We started with these separate, but now they're combined. And they are required to have goals from the T-TPQ built into these plans. So T-TPQ-driven, Perceptions Questionnaire-driven plans built into these goals. One of our added bonuses was that for some of our facilities who were behind on getting their annual or triannual hospital culture assessment completed, and they were coming up on Joint Commission survey, we told them to pull out their Perceptions Questionnaire survey, and they did so. Joint Commission surveyors have been accepting this survey as to meet the requirement for their culture survey since 2013. So that was one of our bonuses. So about 2 years after we did the first baseline, we conducted the T-TPQ again. And just a side note here, looking at the slide, each one of these bars represents an average score of the 7 questions in each construct. So if you remember, team structure had 7 questions, and so that was the average. And so we took the person who created this slide, I just realized, has pre and post TeamSTEPPS integration on, but it's really not pre and post. It's our baseline and then our 2 years later. But in 2013, it was a really exciting time for us because if you're involved in a TeamSTEPPS implementation, you hear frequently, this stuff doesn't work, it's not working. So 2 years later, we were able to show a statistically significant change between our initial implementation and what we had managed to do. And each subsequent survey since then, we continue to see improvements across the constructs. And the true impact of this survey really is at our hospital and clinic level. I'm showing you data for our enterprise, but our teams are using this data to focus their efforts. So I'm going to show you some examples. We'll be taking a look at a few examples of how we put the T-TPQ to work in the Army at multiple levels, and in developing system-wide teamwork improvements for hospitals to utilize, and then again for our clinics. But of course, I want to make sure you're all awake, so I'm going to ask you another polling question. So what area do you think a large medical organization might score lowest in? I'll tell you that the answer was a surprise to us. And it was also, it continues to be for us, the same answer over and over again. So we're thinking staff empowerment because we know that that's a huge issue for patient safety. When I was the patient safety manager in Heidelberg Army Hospital, before I got TeamSTEPPS, I would review all the patient safety reports. And over again, it appeared that our #1 issue was communication. All the PSRs came down to communication. However, when we found TeamSTEPPS and we put the first perceptions questionnaire out to our staff, this is pretty interesting results here, but when we put our first T-TPQ out to the staff, we were surprised, even at the small hospital, as to what the staff perceived as the #1 problem, and that is peer-to-peer conflict, which happens to be question number 28 on the perceptions questionnaire. So, great. Thank you for sharing that. That's for us, too, was pretty eye-opening. Our #1 issue is peer-to-peer conflict, so we recognized that we needed to improve the use of desk scripting, which is the tool for peer-to-peer conflict across MedCom. So, and also checkbacks, which is fleshed in 23. The interesting thing with desk is every year, not only do we see it across MedCom as our #1, but our facilities see that as their #1 issue. And that's what we saw at Heidelberg when I was working there. So for me in Heidelberg as a patient safety manager, where all my efforts were going on, were focused on other communication issues. How can teams communicate? The question we asked ourselves was, how can teams communicate effectively when they're struggling with peer-to-peer conflict? So we really needed to get to the root of that in Heidelberg, and we're working to get to the root of that here now across our Army organization. So one of the things that we did, besides situational awareness for all our teams that this is our issue, we have the ability to build a standardized readiness tracers, and we built them into our Joint Commission tracers toolkit that our teams have. So at the corporate level, we built these traces specific to desk and checkbacks. And they are encouraged to use these during their readiness tracers. So they go out front line and talk to their staff about this. So it's an opportunity to see how staff is doing, and it's also a coaching opportunity. We encouraged the building of a culture brief into all newcomers orientations. So it's not, we're not asking about it, we had to have a TeamSTEPPS training, but rather a honest discussion about what teamwork, expectations, and responsibilities are at the individual hospitals. And so talking about expectations and setting responsibilities for these new team members. And then we also recommended that they add a leadership annual evaluation goal to their leaders' annual eval. We all do evaluations, right? And so leaders have many competing priorities. If they're rated on how well they role model behaviors of high-performing teams, this will remain a priority on their radar. So that's what we did with our data, looking at it across the medical command. And the leadership piece, if you remember, we had statistically significant improvements in all of our constructs with the exception of leadership. Even though our numbers went up, it wasn't statistically significant. So that's why we focused on leaders in that goal as well. So our next is the hospital. So I had shared with you earlier that hospitals develop their own plans and they develop their own actions for improvement, and they do share those with us. So I pulled up a few actions that our hospitals reported implementing in response to their individual T-TPQ data over the years. As you can see, some are related to a specific TeamSTEPPS tool, so they're going back to their T-TPQ, and others may be in response to a lower scoring construct, as we did when we looked at the leadership construct for all of MedCom, or a bundle of questions and patient safety issues as they relate together. So improving the implementation of leader daily safety briefs. Doctor, nurse, instructor pair, and coaches in each unit. We had a facility that did this and became very successful in getting that implemented. Having this role model is stronger than training and retraining, right? Training and retraining is some of the weakest corrective actions we have. We all know that. Having all hospital leaders and managers instructed as trained as instructors. So you can read those, but those are some of our team's actions. And then for the clinics that evaluated their perceptions questionnaire, some of the examples that they shared with us, for instance, are team briefs for planning or improving the team briefs for planning, improve the use of CUS&2 challenge for mutual support. That's, that is also, some of you had said that you thought staff empowerment was something that needed to be improved when we did that polling question. The CUS and the 2 challenge are the staff empowerment tools, and that mutual support are the team members supporting the other team member who may be potentially making an error or doing something that should be questioned or they feel should be questioned. So using CUS&2 challenge, the utilization of desk to help with peer-to-peer conflict resolution. I could probably spend a whole hour talking about the stories where teams have implemented this and have shown success. But we still struggle because of the history, because of the hierarchy, and we've only been doing this for 10 years. And it takes a while to get things to change. So this is an example of frontline staff using their perceptions questionnaire to develop their own plan. All right. So then, a little polling question here. The next 4 slides are based on this setup. So you are a member. You all are going to be put to work now, okay? You are a member of your TeamSTEPPS advisory board for the facility you work in. Today, the advisory board is meeting to review your TeamSTEPPS perceptions questionnaire results, and you're going to begin the development of your annual plans. Based on the data on each of the following slides, what tools would you recommend that the organization focus on? Okay, so and the next slide. So this is the data, so let's just look at this for a minute. So the green are your agree and strongly agree. That's how we look at this. This is how we in the Army look at this. This is sample data only, but we combine our agree and strongly agree. Our neutral stands alone, that's the blue, and our strongly disagree and disagree are the red. So based on this, there's a question related to this. What tool in this construct, what one tool in this construct would you recommend in your team, your facility focus on? So you need to look at these questions and see how you'd want to make that determination. And there we go. So huddles. And that's because you looked at question number 28, which is staff meets to reevaluate patient care goals when aspects of the situation have changed, huddles for changing. Great. So, you know, I'd kind of like to know, based on this, what your thoughts are for actions. What action might you take for this improvement goal? If you have any, please go ahead and type them in the chat box, and we can all see the recommendations of the team. Creating a script for huddles. Thank you, Mr. Paulino. Coaching on individual units, role modeling, simulation. We do a lot of simulation in the Army. We do a lot of scenario-based. Thank you, Mary. Bring data to the unit. Data is king. If you have this data, data speaks. And so having this is fabulous. Training on how to huddle. Great recommendations here. I would love to, I'm going to save them all, and we'll take a look at them and see what we could do to share and steal in the Army. Set a place. Have a place to have a huddle. Making sure you keep them short. I like these. These are great. You guys have all the answers. All right. So just in the interest of time, I'm going to move on to the next slide. Here's another one. This is these are your results, advisory board, for mutual support. Next, so I think we're on the next. Yep, there we go. So these are your results for mutual support. And so based on these results, well, 100% so far on desk. Let's see if anyone else SBAR. Okay. Again, there's many ways to intervene and how you can develop these interventions. If desk isn't working for you, SBAR could potentially be one of those things you use. But DeskScript is the peer-to-peer conflict resolution tool that was developed for TeamSTEPPS. And I personally have found it the hardest to teach. I've had to learn to master that, and it's the hardest to practice. So you guys were talking about interventions with, using scenario-based and simulation. Scenario-based is a great way to actually practice desking. And I see someone said that Ms. Rettle King says desk can be used in clinic settings and administrative areas. Yes, it can, and we use it here at MedCom. When we need to deal with our peer-to-peer conflict in our office, this is what we use. All right, great, thank you. You're not done yet. Advisory committee, you got another one here. Based on the data below, what tool would you prioritize for leadership? So looking at this data, what tools do you think you need to work on? There's a lot of tools in TeamSTEPPS, and if you want to teach them all, great. But if you want to really focus on what you need to improve on, this is what the T-TPQ will do for you. And you all got it. You got debriefs. And you may, we've got some folks using 2Challenge. You may combine this data with some PSR data or sentinel event data that you have, and you recognize that 2Challenge is something that you need to focus on. And so that this data combined with some other data that you're tracking, that's perfect. All right, and then this is your last polling question here. Communication. So now you've got all 7 answers for communication. And what tool would be the one that you would focus on based on this data? Yep, you can verify in huddles. You can verify with SBAR, but there's nothing like a good check back. And, you know, when I first started in the Army and working as a civilian, and someone would say, I need you to call radiology. Someone would answer, got it, HUA. HUA is not a check back. A check back is, I am calling radiology. Believe it or not, this was one of the, and continues to be one of the top issues that we try to correct. Folks don't understand what a check back looks like. They think they're doing them, but they don't understand, which is why we build these tools for these assessments in our readiness assessment Joint Commission tracers. So that's a great way. We at MedCom, we address this in the sense that we did not want to add new processes to get TeamSTEPPS implemented. So we looked at what we were doing already and how do we build in improving checkbacks into what we're doing already. And we're all doing Joint Commission readiness tracers for ourselves. So why not include that in the tracer? So, okay. All right, super duper. Now, that was fun. I'd like to congratulate this team, this committee for a job well done. You've identified all the areas of opportunity, tools that could provide solutions, and you've begun thinking about possible actions. Once you have your plans finalized for the next steps, we expect that you will brief it to the staff and leadership for recommendations and buy-in. Thank you, Advisory Committee. Yay! Fun. I appreciate you guys. All right, so in conclusion, and to summarize, as I've stated, the T-TPQ has helped to provide focus for our teams at many levels when developing our teamwork improvement goals and plans. We are a large organization and we conduct a survey electronically, but this survey works on paper and stubby pencil. Many of us have been there, and many of us have done that. I would like to thank you all for joining and allowing me to share our organization's experience. For us, this is still a work in progress. We're always happy to share what works for us and our challenges. And now I'll turn it back to the AHA team.
Thanks, Phyllis. That was really wonderful. I really appreciate it. It's nice to get a very, very practical look at how you could use a measurement tool to really enhance and help you plan your implementations. I love the angle you took here. We had some questions coming in, and I encourage people to continue chatting questions in. One of them that kind of looks at the overall survey, and I think you've answered it, but I want to step back to it, was somebody asked, do you focus on building off strengths or working on weaknesses? And in this webinar, we very much looked at working on weaknesses, right? Like, where are there those opportunities for improvement? But have you ever approached things where you've said, this is great, let's make it better?
Absolutely. One of the things that I didn't get a chance to share here is in our implementation and using the T-TPQ, we met quarterly with our teams, with our facilities. We'd get a quarterly webinar like this, and we would talk about the T-TPQ data and how we're developing our plans, and we would ask our teams to share what's working for them. So we would build on the strengths of the team. So even though it was an opportunity for a coaching call from the corporate level or medical command to assist the facilities were actually using it as a coaching call. And in that coaching call, they were sharing their successes, they were sharing their challenges, they were sharing, what worked and what didn't. So I do believe that that's where we focused on the success, because it was our team successful.
Do you know if there is a crosswalk between this and the safety culture survey? I know I've seen a presentation, I believe, that did some sort of that connection, but I don't know if there's an official crosswalk.
Yeah. We've done that crosswalk ourselves.
Okay.
Actually, years ago we did that crosswalk when we were first rolling this out, because we do the hospital survey. We do AHRQ's hospital survey as well, and so we do have that, and I could share that with you if you'd like. And that's our interpretation. I don't know. It's not official.
Sure. No, I think that would be something that would be great for people to see, and we could offer it to them after the webinar. So I know that you talked a lot about utilizing things such as competition to get people to submit the survey and getting their rates up as far as submitting the survey. Have you looked at any other things that were aspects of why certain groups maybe performed better in actually taking the survey? Have you looked at them perhaps through an appreciative inquiry lens, or did you more focus on that competition, competitive aspect?
Well, so because we're so large, initially the competitive aspect was pretty critical to us. What happened with us, our Surgeon General, our CEO, told us, this is what I want you to do, but TeamSTEPPS was so young, our leaders didn't understand it 10 years ago. Many of our leaders didn't understand it. Folks, boots on the ground, they were getting it. So even though we had this edict to get this implemented, it was a grassroots effort. Now what's changed for us is that our leaders, our commanders, our hospital presidents, our commanders, and our Surgeon General all understand TeamSTEPPS. It's built into everything we do. So we no longer have to push as hard to get compliance. This year is not a year that we're doing a survey. However, I'm having hospitals call and ask for a survey because they want to see where they are this year. So it's changed for us. It's no longer having to push. In the beginning, it was a push. Did that make sense?
Yeah, it does. It really does. It's, your culture has really changed to a culture that's interested in doing these surveys and seeing how they're doing. So I think that's great. All right, another question here is a little bit more specific, thinking about mutual support. So do you think that in general, the reason why mutual support levels are not high is because of interpersonal conflict? Do you think there are other aspects to it? Like, I've always thought that sometimes mutual support levels are low because people themselves don't want to ask for help. They feel, very tentative about asking for help, and then it comes out later on that they didn't feel supported. So, I don't know, what are your thoughts on that?
I couldn't agree with that statement more about feeling not wanting to ask for help. I told you earlier that I started in critical care. Asking for help was a sign of weakness where I was 35 years ago in nursing. Yeah. And so there's a great section in TeamSTEPPS about team members fostering a climate where it's expected that assistance will be actively sought and offered. And I believe, and when I do my presentation, I talk about how it's not only important to offer, but also to look for help.
Yeah.
It's an awareness. I've done trainings early in my career where I talked about this mutual support even before TeamSTEPPS, and I would have people in the audience say, look, we didn't get this when we were young, nurses, doctors, whatever. Why do they get it? So the change starts with us. We have to change, and
Right.
That's really what the catalyst has to be.
Yeah, that makes a lot of sense. There's a lot of different elements, I think, that go into, mutual support not being offered, and I think that's definitely one of it too. Is sometimes those attitudes as well. But I think that's definitely changing, like you said.
Another thing, Chris, just quickly, is I hear frequently, if I offer help, I get sucked in for 30 minutes. If you go and you say, I've got 10 minutes, what can I do to help you? If you set a time limit on what your help can be, that helps the person accepting the offer because they understand what your constraints are.
Right. Yeah. They don't assign you something that's, long term. What's something that you can handle right now? I like that.
I can label labs. Yep.
Yeah, that's very good. Well, I think with that, we've covered all the questions that have been texted in. If you have more questions, please send them to the email address we have on the screen here, teamtraining@aha.org, and we'll pass those questions on to Phyllis. She's very graciously said that she'd answer them, and so we'll be able to do that and help out. We also want to remind you how to get your continuing education credits, and those are credits, like I said, that helps everybody. They work for physicians, nurses, allied health professionals, pharmacists, everybody. So you would text to the number that's in the chat box right now. You text that, and then you use the SMS code YASNAM. So that's how you do that. We'll also be sending out an evaluation. We love if you can take a moment and do the evaluation. It's something that we actually go over on a monthly basis here at the AHA, all of our evaluation data to see where we can improve, and we utilize that data to help make the next webinar better. So things like offering CE credits are something that came up through evaluation data. So we try to listen and try to do something about it. All right. There's nothing else. Phyllis, I'd like to thank you very much for spending this hour with us today, and I think everybody really appreciated it, and just like to extend my gratitude for that.
I always have fun coming and talking with this team. Thank you so much, and thanks to everybody.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us this afternoon.